Hi, my name is India Brown, and today we're going to be discussing the post-op precautions for an open reduction internal fixation to a humeral fracture. Following the completion of this lecture, you will be able to demonstrate knowledge of an ORIF precautions by completing a case study. You will be able to briefly define ORIF. You will be able to differentiate between a fracture and a bone break. You will identify the stages of healing post-op. You will be able to classify the types of humeral fractures, and lastly, you will state the common assessments that are used with an ORIF. So, being in the health field, we may hear people refer to a fracture and a break being used differently. They may think because the bone isn't completely broken in half that it's not a fracture. They may only think that a fracture can be like an impingement on the bone. However, with further research, it is determined that the term fracture and break are used interchangeably, and it's just described as a structural break in the bone and its epiphyseal plate or cartilaginous surface integrity impairing that bone. So, what is an ORIF? For starters, the correct terminology is an open reduction internal fixation. So, what happens during this process is that the doctor makes an incision along the arm, and then once the incision is made, he goes in and he realigns the bone and he repositions it together, and that's the reduction portion of it. And then once it's repositioned, he'll then take either a rod or screws to hold that bone back together in the place that it's in its original position. So during a closed reduction, internal fixation is actually going to be the opposite of the open, but with the same goal in mind. So opposed to the doctor having to make an incision, she's going to keep the bone. She's going to keep everything under. There's no need to make an incision here. But what she'll do is do manipulation. And when she does a manipulation, she's basically repositioning the bone back into its original position. And then once it is in its original position, she may use a cast or brace or any type of external device to maintain the position that it doesn't become misaligned again. So there are several different types of fracture, which some earlier were like stress, transverse, oblique. However, there are three different types of humeral fractures. So the first one is the proximal, and by the name, you can usually tell where it is. So for the proximal one, that's going to be near the humeral head, the greater and the lesser tuberosities, in the proximal shaft area near that glenohumeral joint. The humeral shaft, so that's going to be like the mid part of your humerus. And like I said, sometimes that can be determined as transverse, oblique, or comminuted. And then lastly, we have the distal humeral, which I'm sure you can guess. It's going to be the distal portion of your humerus, which could include that supracondylar region and the lateral and medial aspects of the condyle. So here we have our fast fracture facts. First one is going to be that proximal humeral fractures account for about 4 to 5% of all adult fractures, with 50% of those being humeral fractures in general. Humeral fractures are most common in the geriatric population, especially women. Distal humeral fractures account for about 2% of all fractures, and they expect that to triple by 2030. And the most common complications of these procedures can include hardware failure, non-union, malunion, elbow stiffness, and ulnar neuropathy. And you can assume that some of these happen by maybe there's fear of moving it once the surgery is completed, causing those contractures. Maybe they lose feeling after not moving it for a while. Any of those things could contribute to complications of an ORIF. And lastly, studies have also found that epilepsy, dementia, and depression have all been identified as possible causes of proximal humeral fracture occurrences. It is now knowledge check time. So, what type of fracture is displayed in the photo to the left? Just take a few moments to look at that, and then towards the end of the lecture, you'll be able to see all answers to knowledge checks. When creating the protocol for this ORIF precautions for 0 to 8 weeks, a common theme that was found between the studies was that the same treatment guidelines follows for a non-operative treatment can be the same for the surgical treatment of an ORIF. and that is because of the stabilization of the fracture that was provided during the ORIF. So another common theme with the research on an ORIF with the humeral precautions, it seems that most researchers, doctors, therapists, they all get the basis of their foundation when creating their protocol from this three-phase protocol that was described by Hughes and Neer. And they created this in 1975. And it just gives a rundown of the progression and the recovery stages from an RIF from 4 to 6 weeks to 8 to 12 weeks. And as you can see, it starts off easy, but there's always some type of movement, whether it's just range of motion or any type of like pendulum swings. And then, as you can see, it progresses through the weeks, and then with it being increasing weight and changing up the type of exercises. Now, what you may consider whenever you look at protocols is that the weight bearing restrictions may be advised because it varies from person to person, and their primary care physician may have different weight bearing restrictions for them as they go through their recovery stages. So, as stated before, that an ORIF can follow the same guidelines as a non-operative protocol. So, what we have listed here is a published protocol, and it starts off in day one and it goes up to about 6 to 8 weeks. And as you can see, once you read through it, you'll see that it starts off very easy and it's just controlled pain management, edema reduction techniques, and slight range of motion. But as you can see through the days and the weeks, the intensity increases, the exercises increase, and they starting to wean off of the sling. And it also goes into ADLs as well, so that by the time they reach weeks 6 and 8, they should be fully recovered. They should have improved strength. They should be able to contribute to the ADL process, and it should be little to no pain here. So, just an FYI, the more you know, you can Google ORIF protocol, and what you'll find is well known hospitals, well known researchers, and you may find that even like the therapy clinics, they'll have their own protocols listed on their websites, or they may have PDF versions, and they can use it as like a home exercise protocol or home exercise program that they may give to their clients that is also available for the public to use. So, what assessments are commonly used? How do we track the progress of an healing ORIF? Well, we have things like range of motion, and then we also have the DASH, which is also known as the Disabilities of Arm, Shoulder, and Hand Assessment. So the DASH is a 30-item self-report questionnaire, and there's two versions. There's the regular version, and then there's a quick DASH, which is a shortened version. So with this test, it assesses the person's ability and it's their personal opinion of how they would rate themselves in that situation. So for an example, it may ask, how much difficulty do you have opening a jar, or how much difficulty do you have washing your hair? And they may rate it mild difficulty to a lot of difficulty. It just depends on their personal preference, and they can use it as a pre and a post test if the therapist may do so. A more common assessment would be range of motion. And you have the three types. You have the active range of motion when a patient is independently able to move their limbs or body part. You have passive range of motion, and that's when the person needs assistance from another person to lift that arm or limb. And then lastly, we have active assisted range of motion when the patient can contribute to moving, but they still need an additional assistance from an outside force to help move them. And this could be due to anything from weakness or just pain in general. Knowledge check number 2. Assuming this patient independently reached approximately 110 degrees of shoulder flexion, what motion is being performed for her to achieve full shoulder flexion? So, what is OT's relationship in the ORIF process? Well, according to research, OTs can assist with upper extremity rehabilitation. We can assist with ADLs, compensatory techniques, physical and functional mobility, pain management, the restoration of strength and motion. However, when trying to identify protocol, research did suggest that there should be a standard protocol across the board for all practitioners to use. And they also stated that maybe an upper extremity rehabilitation protocol could also be used to help, treat these upper extremity issues, not only limited to an ORIF. Knowledge check number 3. What are some areas that occupational therapy assists with during the healing process of an ORIF? Practice case study. Miss Humeral is a 68-year-old woman who loves to garden. However, during her usual routine of gardening, she tripped over a water hose and sustained a proximal humeral fracture to her right arm. She is currently in week 4 of recovery. Identify at least 3 precautions and or exercises for her to complete on her own.